I've had lots of people asking for more information on our fantastic new Cardiac Surgery for Nurses e-learning course. It's at csuals.org. Just scroll down and click here and you can find all the courses. So we're going to share a few modules with you. You can only see 2 minutes on Twitter, but if you go to my YouTube channel by clicking Joel Dunning into the search function, you'll find some slightly longer examples. But of course, there's no better way than to actually log in and do the course or ask your hospital to provide this course for you. So I hope you enjoy this example module.
Hello, my name is Garcia, and I'm currently a nurse practitioner at Atlanta, Georgia's Grady Memorial Hospital in the Neuro ICU. I also have 5 years experience at Emory University Hospital's CV ICU and have taught CSU ALS in the United States, Mexico, and Costa Rica. In this segment, I'm going to be talking to you about how to recognize and respond to the deteriorating patient. So what we'll be talking about here today may be a little bit different than things that you've heard before. Some of it may be the same, but what we would like to stress to you is to not necessarily go in and do a full body assessment when you think your patient is deteriorating, but to start to look at your vital signs. And we're going to review 10 of them today, which may be more than what you're used to hearing in terms of normal vital signs, but we are going to be reviewing 10 today. So the first vital sign that I'd like to talk to you about is your patient's level of consciousness. When we walk into your patient's room and you get the feeling that things aren't quite right, the first thing you should notice is your patient's level of consciousness and how that might be different from the last time you saw your patient, whether it's 5 minutes ago, 15 minutes ago. Let's say you had gone to help another nurse turn their patient and you come back into your patient's room and find that he's no longer talking to you. That is definitely a change in consciousness if he had been fully articulate, alert, and oriented previously. So that's when you start to say, okay, something isn't quite right, and what do I need to do about it? Other changes in level of consciousness might include extreme agitation, and you'll have to start to think about, okay, why is my patient all of a sudden agitated? Is it due to pain, which is another vital sign that we'll talk about, or is it due to delirium? Have they just been in the hospital too long? Are they a little bit older and have dementia? So it's very important with your level of consciousness and with all of your vital signs to have an idea of what your patient's baseline is and how now they are different than their baseline. The next vital sign that we're going to talk about is heart rate. So heart rate you'll typically see on your monitor, especially if you're dealing with a post-op cardiac patient. Heart rate is a very important clue to us as to how our patient is doing. But again, you'll want to keep in mind what your patient's baseline is. So looking at the heart rate, you're going to want to see, is it fast? Is it faster than what you expect? Or is it slow? Now, many times in a post-op patient, we'll see a little bit of an elevated heart rate, and that may be due to a SIRS response, an inflammatory response. It could signal that you're looking at getting a little septic, or it could just really be their baseline. A fast heart rate is some people's baseline. So you'll want to make note of that. If your heart rate is slow, what is your patient's baseline? Are they a marathon runner? Typically, you won't see a marathon runner who needs heart surgery, but there are some cases in which you might see that. So you would expect to see a lower heart rate. And there are some people, just like people who have normally baseline fast heart rates, you can have patients who have slow heart rates at baseline. So know what your patient's baseline is, how they are varying or veering from that norm, what we expect to see, and what might be causing it. You'll also want to note whether or not your rhythm is regular or irregular. Of course, a lot of times post-op we can see different rhythm changes because patient's electrical conduction system has been irritated by whatever procedure they've undergone. Or perhaps they're in your unit for cardiac ablation due to protracted atrial fibrillation. So is the atrial fibrillation still there? Has it resolved? Is it coming and going? And how is it affecting your other vital signs? and your patient's general overall clinical status. For example, there are some people who, with a fast heart rate and SVT, they may maintain their blood pressure. Other patients may not. And it's the same thing with atrial fibrillation. Sometimes in a slow enough rate of AFib, blood pressure remains stable and you don't necessarily have to intervene immediately. However, other patients cannot tolerate atrial fibrillation. They lose that atrial kick, that extra 20% of cardiac output that a nicely contracting atrium will provide, and their blood pressure plummets. And so that requires some immediate intervention. We'll also want to take a look at your patient's blood pressure. I started talking about it a little bit just a moment ago with respect to losing atrial kick and atrial fibrillation, but there are many, many reasons that a post-op patient may find themselves a little hypotensive. Again, you'll want to know what your patient's baseline is or what the goal is for your blood pressure. Many times in a cardiac ICU or in a cardiac unit, you'll be expected to maintain a patient's mean arterial pressure or MAP above a certain goal in order to perfuse your end organs. So you'll want to take a look at your MAP if you have an arterial line in place. If you're in that kind of environment that uses arterial lines, you're somewhat lucky because you have beat by beat blood pressure, but you also need to take a look at the tracing. Is it dampened? Is it artificially deflating your blood pressure because there's a clot at the tip of the arterial catheter? So these are all some of the troubleshooting things that you need to go for before you sound an alarm. Otherwise, you call valuable resources to the bedside needlessly and also run the risk of making yourself look a little foolish. So take a look at your tools and troubleshoot them. Don't take too long to troubleshoot. If you really start to think you're in trouble, call for trouble, but do take the time to troubleshoot. If you don't have an arterial line and you're using non-invasive blood pressure, what you may want to do is use one arm and then switch the cuff to another, see how they compare. You'll also want to pay attention to hypertension. We typically see hypotension in our post-op patients, but patients can get hypertensive as well. And if you get to a certain threshold, you run the risk of destroying grafts, for example, in a cabbage, or if you have a patient who has not yet gone to surgery and they're being medically managed for, let's say, an aneurysm, we'll want to pay attention to hypertension because it can lead to rupture of an aneurysm and very, very rapid decline. So make sure that you're adequately assessing your blood pressure. Again, use both arms if you're not getting a good reading or if you suspect anything being wrong with one arm. If, of course, a patient has a history of breast cancer, mastectomy, or any other kind of vascular compromise in their upper extremities, you can use their lower extremities, just keeping in mind that it may cause some variation from what the upper extremities may provide. Again, look at your arterial tracings, make sure that you're level. That is one thing that we often forget to do especially if patients are able to turn themselves. They may be sitting up or sitting down, and it changes the reading in your arterial waveform because you're no longer at that phlebistostatic axis or second to third intercostal space at midline. So make sure your A-line is level. When we talk about a patient's temperature, the thing that automatically comes to mind is fever. So it's important to know what your institution's guidelines are in order to appropriately alert to elevated temperature and to treat elevated temperature. So in the institutions where I've worked, the threshold is always 38.5 degrees Celsius. And that is when we start to notify our providers and attending physicians that, hey, this person has an elevated temperature, and should I give Tylenol or do we want to see how high it goes? And then we also want to make note, if we do administer some kind of antipyretic, we want to keep track and make sure we know if the patient's body temperature is responding appropriately. What's the point in giving 650 milligrams of acetaminophen and the patient's temperature is still 39.2? That's when we need to say, okay, what else can we do to bring this patient's temperature down? So it's not just about making an immediate intervention, but tracking these vital signs so that we can intervene appropriately. Conversely, we want to pay attention to whether or not a patient is hypothermic, because that presents problems in and of itself. Typically, we think of hyperthermia in terms of infection and sepsis. However, patients can become hypothermic in sepsis situations as well, sometimes because of a lack of perfusion caused by sepsis and severe vasodilation. And again, sometimes they can just be hyperthermic. Hypothermia is very frequently seen in our post-op patients because the environment itself, the physical environment in the operating room, can be very cold, and because they're receiving a lot of fluids at room temperature, which is, ambient temperature in the OR might be 68 degrees Fahrenheit, but your body temperature is much, much warmer. So that difference will automatically bring a patient's body temperature lower. So one of the things that hypothermia can do is cause a change in level of consciousness. So when people get cold, they get confused. Those are some things that you need to be aware of, in addition to a hypercoagulable state and hemodynamic instability. So being cold can be just as dangerous as being warm. So don't just ignore a low temperature. Start to, again, know what your patient's baseline is. Some of us run colder than others, but if you deviate too much from what your expected value is, make sure that you take it into account, add it into the picture that you're going to paint of your patient and their condition, and think about what might be triggering this change in your expected value. Okay, we're going to talk about pain for a moment. Pain is important because it can cause changes in so many of our other vital signs. A lot of research has pointed to the fact that elevated pain can cause an increase in blood pressure, and it can cause an increase in respiratory rate. There's some weaker correlation between pain and your heart rate, your pulse. Sometimes you see an elevated pulse, sometimes you don't, but it is another thing to take into account when you're assessing for a patient's pain or when you think they might be in pain. Of course, the patient who is able to verbalize their pain is really the best case scenario, because then it's easier to find out what works to alleviate their pain, where their pain is, what's causing it, et cetera, and how to best manage it. In patients who are nonverbal, you can look for physical clues such as a furrowed brow or guarding of some sort. And then, of course, as you start to inspect and palpate, if you have the time to do so, then you can physically pinpoint where it might be, where a patient's pain might be coming from. Another important thing to consider when you talk about pain in a post-op patient is that if they've had a midline incision and it's causing them a lot of pain, they will most likely find it difficult to take deep breaths. And we know that the inability to take deep breaths or turn or cough and deep breathe can cause atelectasis and pneumonia. So when we talk about controlling pain in the post-op patient, it's not just important because we want them to be comfortable. It's important because we need to avert the sequelae of the inability to breathe deeply. We need to avoid pneumonia. We need to avoid atelectasis. So pain is best controlled, and then we can avert all of these untoward events. A patient's respiratory rate can also clue you into a lot of different things that may be going on. Of course, you'll want to note whether or not they're breathing rapidly or slowly, because they can signify different stages of their condition. We know that normal respiratory rate is anywhere between 12 to 20 breaths per minute. And we also know that when a patient starts to breathe very quickly, 30, 40 breaths per minute, they can often tire out. Breathing is hard work, especially for patients who are deconditioned or have comorbidities to begin with. So it can sometimes be very easy for patients to go into respiratory failure if they sustain rapid and hard work of breathing, laborious work of breathing for a long period of time.
So I hope you enjoyed watching that example module. Remember, you can find the full course at csu-als.org. We're just showing you where to find it on the website here. There's basic, intermediate and advanced. Of course, it does cost if you do it directly, but perhaps ask your hospital if they can get in contact with us and provide it for you for free. We're very happy to work with hospitals because this is such a valuable and useful resource for everybody. So ask me any questions if you like. Just put Joel Dunning into Google and you can find my website, and I'd love and appreciate any feedback you might have for me. Thanks a lot.